So if you have any questions later after seeing these recordings or anything like that, please just let us know. We can reach out to the appropriate people and probably get them answered. So I will let Boban take over, and then he will introduce KK, and then we'll start with the presentations.
Can everybody hear okay? Yes. If there is any problem hearing or seeing us, just text it, type it. You can turn the audio on, but if it shows reverberations, we can stop it. So I want to quickly introduce Dr. Krishna Kumar. Most of the people in our group doesn't need an introduction for Dr. KK, but there are other folks who will be listening in that are not necessarily pediatric cardiologists. So first of all, I'm Boban Abraham. I'm from Kerala originally. I have had the good fortune to work with Dr. KK at Amrita on several occasions. So Dr. KK grew up in different parts of India. That's what I know from talking to him because of his dad's career. And he speaks many different languages. He speaks English, Hindi, Telugu, Malayalam, obviously Hindi. And it's amazing to see him switch back and forth depending on where the patient is coming from or who he's talking to when he's in the OP. He did his MBBS from Maulana Azad and finished his cardiology and pediatric cardiology training from AIMS as well as from Boston Children's. He has set up a world-class pediatric cardiology unit at Amrita in Kochi. He's a pioneer in low-cost innovations and a very renowned interventional pediatric cardiologist. He is also a leader at PCSI and a past president. He's trained a lot of people, that's what I came to understand, who are now working and setting up their own units in different parts of India, as well as in other South Asian nations. And some of us are here even in the US who has been trained by Dr. KK. But above and beyond all of this, I think what I have learned is he's a great, compassionate human being who wants to do the maximum good to kids and parents that he serves. So the list goes on and on, but that's I'm not going to take up any more time. We are very fortunate to have Dr. Krishna Kumar talk to us, associate with us. He's at PCSI and it's early in the morning. So thank you for coming online, and we look forward to hearing from you.
Thank you, Boban. I can't thank you enough, actually, for what you've done for just raising the awareness and putting this whole network together. I think this may actually translate eventually into something quite substantial. And really thank you. You've generated a huge amount of momentum. So this is also very nice, the way you set up this internet-based exchange. And it's given us a lot of ideas of potentially having more academic exchanges between your community and the pediatric cardiac community in India. So I will not waste too much time and spend a little time just introducing the whole situation in India to the audience there, and just explain to you the magnitude of the problem. So I've titled this talk as Challenges and Opportunities because I think they come together. And essentially, I know that you've introduced me to the audience, but there are some aspects that I wanted to tell you about myself, essentially in terms of what led me to become a pediatric cardiologist. And I trained in All India Institute, did my DM in adult cardiology, predominantly adult cardiology, in 1990, because there was essentially at that point, I was trained as an adult doctor in adult medicine, and then I did my DM in cardiology, and I finished in 1990. I was inspired by Dr. Tandon, who who was actually a pediatric cardiologist. He trained in Boston Children's in between 1961 to 64 under Alexander Naders, but was not given the opportunity to do pure pediatric cardiology. But was brilliant and really very inspiring as a teacher. And I think I became one of his first few students who committed himself or herself to exclusive pediatric cardiology. And from then on, actually, Dr. Tandon wrote a letter of recommendation, and I was accepted in Children's Hospital, Boston, essentially exclusively because of that recommendation, amidst pretty high competition, but entirely because he made the recommendation, because his credibility was so high, they respected him so much, and I was accepted to come to Boston Children's Hospital in a very remarkable situation. They made several exceptions. An overseas doctor who hadn't got any pediatric training, from an adult cardiology background, with no interview as such, I had a telephonic interview. All that was done just because of Dr. Tandon. So I came to the US in 1994 and did a fellowship between 94 to 96. For a variety of reasons, I had to commit myself to go back to India, not all of which were necessarily noble causes, some of which were family compulsions. And I, in 96, found a job opportunity. When I went to US, I was told that what you're doing is virtually professional suicide. There's nothing that's going to be available for pediatric cardiology in India. You just have to really end up staying in the US. But in 96, midway through my fellowship, I hadn't completed my fellowship. Just 2 years into my fellowship, I got a job offer from Escorts and in Delhi, and this was one of 3 or 4 pediatric cardiac programs in India. I couldn't come back to All India Institute because I had to resign to go to US to train. So when I came to when I got this opportunity in Escorts, I sort of quit my fellowship program and came back. I thought with 2 years of training I was okay, and I decided to come back to India and see what I could do. I came to Escorts Heart Institute, and the situation in India was fairly primitive. We were operating at that time, I think, about 1% of babies who needed surgery in 3 or 4 centers. The centers that were capable of infant surgery, there were 2 in Chennai, 1 in Trivandrum, and 2 in Delhi. Essentially, the Delhi centers were All India Institute and Escorts, and that was it. There was nothing else in India that was, truly pediatric cardiology. There were centers doing congenital work, but pure pediatric cardiac surgery, infant heart surgery, was virtually non-existent. And what I had seen in Boston, and when I came back, it was a sea change. But more importantly, I realized at that point that I was really not able to take care of most children. In fact, when we were in Escorts, it was a private center, it was a new private center, there were no avenues for funding, so we were really turning away a lot of children. It was very frustrating, and actually at one point I was pretty close to going back to the US just out of frustration. But then, I think it's all a story of right opportunity at the right time. The challenges that were there were quite, as I listed, quite serious, and the patients were much sicker than what I had seen in the US. There was also a very firm attitude that none of this is financially viable. It's actually not possible to do this in a sustainable way at all, and this is not going to work. I was mostly discouraged. But something was happening in Kerala. Kerala was ahead of the rest of the country. The important thing at that point was, India had a fairly high infant mortality overall. Even in 1990, it was an unacceptable national average at that point of time. And but Kerala was completely different. And congenital heart disease had already surfaced as a significant cause of infant mortality in Kerala in the 90s, while the rest of the country, it was drowned by other pediatric causes. So it was pretty different right then. And there was a very strong felt need for an affordable infant and newborn heart surgery program. that was perceived by the public and the medical fraternity as at large. So that was the situation that actually set the stage for the Amrita Institute. And this was 1997. 1997, I was interviewed at, and this was exactly the kind of situation at AIMS. I came in here, I saw this construction, and I met these two people. I met Prema, who looks very different now. Like me, he is grayed almost significantly. And then Ron Gottsagen. Ron is an American who was setting up this project in Kochi. And these two were very inspiring. They presented a vision of actually trying to reach out to the average family. And there was a real commitment I could see in their eyes. And so although nothing was really clear, there was just a building, I felt that I could actually start a career here and make a difference. So I accepted to join, and the initial period was quite challenging because actually I remember the first day, there were 150 patients waiting outside because the word had already reached the public and we really weren't ready. So I had to set up my echo machine in one of these rooms with all construction happening around me and get started because patients were waiting, and we started our clinic right under these circumstances. But then it grew very rapidly and things became quite fantastic. I also, we described our goals, which was cost-effective patient care. And I think this was very close to my heart. And that really made the difference in terms of encouraging me to join. And I think we set out with these goals, which was articulated by everybody who was part of the program at that point, including the administration. And these were sounded actually quite utopian at that point. There was also a strong commitment to training and teaching. And there was a very clear mandate for research. And I stated our research goals as trying to make it as contextual as possible and really understand and address the unique problems relating to pediatric heart care in our part of the world. And I was fortunate to have very good colleagues who joined me. I think some of you know Aarti. Aarti is right now in Seattle. But Aarti was, along with Shelby, were my first fellows. And they came in and joined this really difficult circumstance. I was all alone. And said, okay, listen, we'll kind of join you and see where we go. They expressed an interest in becoming pediatric cardiologists, and there was nothing really in terms of training them. So they just joined me and we started working together, and that's how it began. But what happened then on was quite remarkable. I think the program grew, and we actually finally found a lot of things happening and falling in place. But I listed out the reasons why this worked. And I think this is important to recognize because there were many folks from the US who've come to India with the hope of trying to establish something and do something for the country, and they haven't been successful. And it's not because they didn't want to be, but because they were not in the right place at the right time. And I think that's critical. I was exceptionally lucky, and you'll see why in this particular slide as to why I was so spectacularly lucky. And not everybody has this extraordinary opportunity. I was given a fantastic infrastructure, and then the best equipment. What I was told in AIMS was whatever is realistic in 1990s will be provided to you. And I got a number of caregivers who joined me who were very skilled, good nurses. I had a skilled surgeon, Dr. Suresh Rao was with me. Then very good junior colleagues. And then we embraced this whole concept of coherent teamwork. We all came in together. So there wasn't this, hierarchical situation where there is one monolithic boss who decides everything. And that was a situation in many other Indian institutions at that time. An administration that was remarkably supportive, who also embraced the ideals that we were seeking to pursue. And a very mature and developed referral base in Kerala. In Kerala, I didn't have to do any marketing, I didn't have to tell anyone. The word just spread. And the Kerala was ready. Kerala had the favorable economic and, more importantly, human development. Infant mortality had come down. And the hospital immediately established a system for charitable care. And then, of course, there were sustainable systems for education and nursing that the hospital was seeking to establish right then. Otherwise, none of the efforts can be sustained. And then, of course, they embraced, and the whole practice environment in Kerala was, and to substantial extent still is, very ethical, not totally profit driven. At no point in my last 20 years I've been asked to questions about the money that's being generated by the program, whether we are making profit or not. So I don't think you can get this in many institutions. You need to be exceptionally lucky for all this to happen. So I get a lot of credit. All my life I've been given credit for establishing something special, and KK did this and KK did that, but it's actually not that. It's actually being in the right place at the right time. And I really wanted to put this on record, particularly for those of you in the US who are thinking and maybe a little guilty for not having done enough for the country. And I have to tell you that the opportunities don't always come by. And it's only when they come by, you have to embrace the opportunity and be persistent. That is very important. So yes, it happened. It happened in 1990s. In 1997, 98, we were ready. And then, of course, very rapidly, we grew into a remarkable program. A program that was able to then put in all the elements of pediatric heart care. We had a lot of my fellows have actually, I'm the only one that remains. What remains of me is a lot of gray hair. But all of them have left elsewhere and started programs. All these were the surgeons, Suresh Rao and Shiva and Baiju and Sajan and Girish. They're all running very successful programs elsewhere. It's all been replaced. The anesthesiology team also has been replaced substantially. So, much of this has changed, but the philosophy of teamwork and everybody coming together in the interest of the child has remained. And this, in many ways, has become the role model for the country. Many institutions have embraced the concept of teamwork, which didn't exist really in the mid-90s in India, and how they've seen how successful this is. Nonetheless, the magnitude is enormous. The population of India is quickly going to overtake China. That translates, actually, the number of children born in India is already more than what's happening in China. 27 million children born each year. And if you take a very conservative estimate of congenital heart disease that is serious, that needs attention in the first year of life, it's about a third, 3 per thousand or 3.5 per thousand. And that translates into close to 100,000 babies born each year with very serious congenital heart disease. And critical congenital heart disease, a newborn that requires attention in the newborn period, is also pretty substantial. Now, none of this is really a guesstimate. It's all based on a very real study. We did a pilot of the study in Amrita, and then it was translated into a very large study by Dr. Anita Saxena, because they had access to very large numbers. They nearly recruited 20,000 babies and did echoes in all of them. And they found essentially these numbers. And these numbers were the exact same numbers that we got. So I think this can form the basis of making national estimates. And the national estimates are staggering. Obviously, you expect that because of the number of live births that happen in India. And what's important to recognize in India is that, while congenital heart disease rates are relatively constant, the infant mortality from all causes is coming down. So congenital heart disease is really starting to surface in many, many parts of the country very significantly. Tamil Nadu is experiencing that phenomenon quite visibly. Goa, Punjab, Maharashtra, these are all places where the infant mortality has declined and congenital heart disease has started to become really, really important. And not just that, it's just the level of attention that's now being given to children as the society develops. And that's also something which is quite impressive. This is the state-wise distribution of decline of infant mortality in India. Kerala has always been ahead. But unfortunately, in Kerala, it's kind of plateaued, and it's this plateau is being attributed to our failure to address congenital anomalies, including congenital heart disease, and that's something that we are trying to do, and it's of course much harder than the other preventable infant mortality causes. And you can see all the states are showing decline. Some faster than the others. Some are at such a high level of infant mortality to start with, ridiculous sub-Saharan African levels, that they are having a lot to do in terms of catching up. So this is the kind of situation we are in India right now. This situation with our failure to address congenital heart disease translates into a massive burden of uncorrected congenital heart disease. So you have adult congenital heart diseases, uncorrected congenital heart disease, and I think you need to see Boban has come and seen some of the problems that we see with uncorrected congenital heart disease. So that's a huge problem: pulmonary hypertension, Eisenmenger syndrome. These are 4 very illustrative slides. Actually, I've stuck to this for the last 20 years. I've been showing these slides because nothing can be more graphic. This is the first. This baby that's there on the top left is a baby with a cyanotic spell that came from Munnar, which is a hill station, and took 6 or 8 hours to get to Kochi because they stopped on the way. This was a bad cyanotic spell. The baby, by the time they reached our ER, actually the cyanotic spell disappeared, had cleared off, and the child was saturating in the 90s. But the spell created this massive watershed infarct, and actually the child was brain dead. And it was heartbreaking because this is something that was completely fixable. These are pictures of brain abscess. This is a brain abscess of a child that was transported over a very large distance on prostaglandin, which was administered by the parent because the child was air transported. Actually, this is a Malayali kid from Saudi Arabia. But essentially, to illustrate the same impact of very poor hygiene during transport, which resulted in this massive brain abscess, presumably from the IV cannula. This is a picture of extreme polycythemia that results in spontaneous contrast. But I think to show you these covert neurologic damage is just to illustrate what happens. Overt neurologic damage is just to illustrate what happens in a covert fashion, which is the neurodevelopmental impact of congenital heart disease on these children that makes them fail to realize their true potential. I think there's a lot of neurologic damage that is really unrecognized. Undernutrition is a problem that we see. We haven't come to terms with it really in India. There is a background, as you know, of very strong background of undernutrition in India that is the result of a variety of known social causes and perhaps some unknown reasons as well. This is a particularly illustrative case of a child who was 2.5 kilos at 6 months. This child was 3 kilos at birth, and this actually opened my eyes because this child was not being fixed because he needed a certain weight threshold. And we decided to fix him. And it was very interesting. We were also uncertain at that point, but the parents egged us on and said that we're just not making any progress. You guys fix the baby, otherwise we will accept the high risks, but we just can't do anything more at this point. And we did it, and this child did well, and really this was a paradigm shift for our program, which allowed us to really change the face of management of large left to right shunt. And we wrote a bunch of papers on this situation that even in extreme undernutrition you can get remarkably good results. And actually birth weight and weight at surgery had a very, very minimal impact on outcomes. Similarly with pneumonias, we had children coming in with very bad pneumonias on a ventilator, and there was tremendous reluctance to operate on them. And again, we realized that unless you fix these lesions, you don't have to palliate with a band, but you just fix them and they would do well, and they do remarkably well. So this was another eye-opener. But yes, we still continue to grapple with a lot of problems in India. There are health system challenges that impact congenital heart care substantially. There are the overall primary and secondary healthcare in most of India is poorly developed. And that translates into very poorly organized transport. And Boban has seen this all. Boban has seen the impact of a poorly organized transport and what it does to infections preoperatively, the high prevalence of multi-drug resistance, the poor development of other pediatric subspecialties. Again, Amrita is a real exception, but elsewhere, pediatric cardiac specialties are existing in isolation, and that's not a very healthy situation because children with congenital heart disease, quite often have other issues that need to be dealt with very professionally, and that's not happening. So these are our challenges that really are very beautifully illustrated in the slide that Dr. Srinath Reddy has made, who is the chairman of the Public Health Foundation. And essentially, India has a mixed health system that does not assure access or affordability to a large number. We still have maternal and mortality rates infant mortality rates that are unacceptable, largely from the fact that over a third of births are unattended by a skilled health worker. We have a very high burden of infectious disease and childhood malnutrition, a rapidly rising burden of non-communicable diseases, and public financing is only 1.2% of the GDP, and most of expenses is out of pocket. And this is a terrible, terrible situation that impacts especially the care of congenital heart disease. So if I were to set out this slide, some of you might have seen it before, a sort of a game plan for pediatric cardiac care in India. And I did this when I sat in Amrita when we developed the center. I said, if we have to develop pediatric heart care in India, we need to do these things. We need to define deliver burden, deliver care, and then improve awareness. And we've done something. We've really done a fairly good job in we've got very good data on rheumatic heart disease, on lifestyle-related diseases in selected situations, and congenital heart disease. So we've done this mostly. Delivering care, I think this is the very essence, to develop good institutions, academic institutions that are affiliated to university programs. Because a lot of things are very rooted in our context. We needed to train our own caregivers, develop our own technology, really, because we can't completely depend on Western technology, and it's not going to be cost effective. We need to develop our own cost effective strategies, develop and again find ways to generate resources for our patients. And it's fantastic how this association with Genesis Foundation has happened. And then all our research should be rooted to understand, substantially, much of our research should be rooted to understand our population and our needs, and that's happening. And the Pediatric Cardiac Society of India really has embraced a lot of these ideals. And at the same time, it's important to improve awareness amongst general population, policymakers, pediatricians, and that's happening again, and other caregivers like OBGYN and adult cardiologist and radiologist when it comes to fetal echo. So this is kind of the big picture we're lumbering along, we're kind of moving along with some success. We've had several new institutions come in. Our outcomes have really improved, especially with catheter-based treatment in many institutions. Pediatric Cardiac Society has been put together. We're working on capacity building. We've trained a number of pediatric cardiologists. We have a long way to go, of course, but we've made a beginning. And this is translated into a real change in the national map. So we've got so many more centers that have come in the last 20 years. And I'm really, really very, very rewarding. I shouldn't be saying proud to say it, but then, it's very, very satisfying, gratifying to know that in this particular part, of the southern part of India, we have, I think, 34 of our trainees from Amrita Institute that are practicing and setting up programs elsewhere. So this is tremendously gratifying. Again, it's just the effect of being in the right place at the right time and starting the right program. But this hasn't translated very much into patients, really, in the impact of patients, because just the disease burden is so enormous. We are only reaching 7 to 10% of the patient population. So that's kind of the big frustration, but that's the big challenge right now, and that's what we're really trying to address in this particular series of activities. Resources, what is needed in India is one center for 5 to 10 million. That means 200 to 500 large pediatric heart centers. with each center having 4 to 5. That's the realistic number that we in India can come up with. 2 to 3 heart surgeons and 3 to 4 intensivists. And what we have really is 20 to 50 centers. It's about 10% of the requirement, a real shortage of dedicated pediatric heart surgeons. And you know that is very hard to come by. And but this is a little better, even though the needs are substantially less than what's needed. But we really have made some progress here. And this is largely because of the fellowship program that we set up. And of course, we have a serious problem with pediatric cardiac intensive care, and trained nurses are always in short supply. So this is kind of where we are at, and we need to work continuously towards that. More importantly, the distribution of our centers are very skewed towards the developed parts of the country. You can just see how these arrows are kind of conglomerated and accumulated in parts of the country that are capable of taking care of these patients, that have a good human development index. And again, clustered in metros. Bangalore, Chennai, Hyderabad, Bombay. Right now in Kochi, you'll be surprised there are 3 pediatric cardiac centers. And then Gujarat, New Delhi. So it's all clustered here, and it's not a good sign really, because these centers are actually competing viciously against each other in the face of scarcity elsewhere in the country. And this is the Kanpur-Chennai line, and you can see the difference, but actually the line should be more like this, which really shows you that a very large part of the country has no access to resources. It's a very bad situation for Eastern India, for large parts of Central India. But again, it's mirroring human development. The lowest human development indices in the world, not in India, in the world, are in some districts of Orissa, Bihar, and UP and Madhya Pradesh. So the Indian situation continues to be challenging. 100,000 kids at birth, and we are operating on 7,000 to 9,000. The barriers are several: poverty, ignorance. It's all still a huge problem in India. But I think the barrier that's most hurtful is economic barriers, because we studied this from a family perspective and published this data in PLOS One recently from Amrita Institute. This was a grant-funded study that just was eye-opening for us. Because the average income, and what we saw, depending on the RACS category, for total hospital expenses, both direct and indirect to the family, was $150,000 for the straightforward surgeries and 2.5 lakhs for the more complex surgeries. And this is the equivalent in US dollars. This won't be the amount you'll pay in the US, but this is the equivalent of this kind of money in US dollars. And what's more worrying is the fact that the median expense was about equal to that of the family income. And most of the family did not have insurance. Insurance was actually less than 5% in this particular study. And more than that, there was a 35 median man-day loss and 15 median job day loss. Many families actually broke up. Many families had situations where they had to borrow, and these were the statistics on what they had to borrow from relatives, pledging gold, private loans, etc., etc. All very depressing statistics, because these things would set these families back. And remind you, these families were not the poorest. The poorest don't seem to make it, don't surface in our consciousness, and they're not actually being taken care of. In our own study, we didn't have many patients from the lowest socioeconomic category. That was the demographic distribution, because they just don't make it, they don't surface at all as far as picking up heart disease is concerned. So this is very depressing statistics. When you actually scratch the surface, you come up with very unpleasant truth. And we really have this as our challenge today, which is to overcome economic barriers. And everybody is making an effort. There are government subsidies which are through the Rashtra Bal Swasthya Karikram. That is, I don't think, sustainable. And we are trying, the government is making an effort. There are aspirational statements made by the government, but not much of it is translating really into the ground level, into helping patients. State insurance schemes are talked about a lot, but then they're only there in a very few states and not very well implemented. So this is where the role of NGOs come in. And again, I've put Genesis as the #1 in my own experience in Amrita Institute. We've been supported more by Genesis than by anything else. But these are the other organizations that are also chipping in substantially to help out the patients. But our experience with Genesis has been truly spectacular because they have been completely unconditional in the way they've supported surgeries, and they've embraced the really difficult surgeries, which nobody else is willing to do. In general, foundations want to fund the easy ones. And the easy ones, actually, if you fund them deeply, if you see it very carefully, it may not make that real quantum difference in terms of lives. So that's a bit of the paradox. But again, it's not very easy to accept a poor outcome if you fund a child. So it's a bit of a risk that you take. But it's again started to happen in India. Okay? It's a question of really improving, to taking the awareness to a different quantum level. The other thing that it's important to share with you at this point is the fact that not all of this efforts is futile, because outcomes in Indian centers have improved dramatically in the last several years. And I just wanted to share some of the outcomes which we had at Amrita Institute with you. We actually are a part of the IQIC network. I think some of you are aware of it. This is a Boston Children's Initiative, which now has globally nearly 40 centers, 39 centers globally from low and middle income countries. India has the largest number of centers participating in IQIC. We share our surgical outcomes with a common platform and benchmark it with the average of all these centers and see how we are. And a host of quality improvement initiatives are implemented through the IQIC. It's a fantastic story that I can share through maybe another interaction at some point, but it's translated into huge improvements in outcomes in many centers. It allows also us to look at our results very systematically. And if you look at the special challenges that we were focusing on, because of the IQIC, we made a shift in the way we look at things. All this while we were talking about resources and patient population related issues that were responsible for our poor outcomes, but really we needed to focus on these elements, on the subtle elements. And what IQIC did was to enable that. It enabled us to focus very, very, very deeply on infection control, on implementing surgical checklists. None of this is very expensive. Clinical audits, and then encourage to us to overcome the cultural barriers, which is teamwork, communication, nurse empowerment. And these things actually translated into something fantastic in our own center. And what I'm going to show you is what we've done through the IQIC program. So our surgical mortality, when we started in 2010, when we got into IQIC, was better than the IQIC average. That's probably because we had more resources in our center. But even with that, even from starting from 4.4% in-hospital mortality, we came down to 2.2 because of what we could do with IQIC. And then we also had a terrible situation with bloodstream infections, which we brought down, even though it was higher than the IQIC average. And we really are continue to be challenged by this problem, but we really could bring it down with the help of IQIC. And surgical site infections, of course, was a dramatic improvement. So this has been a fantastic success story because it doesn't involve much in terms of technology and costs, but it's something that you take for granted in the West. But but it really needs to be implemented here in this part of the world. And this is just a snapshot. For a period of time, we were actually spectacular in Amrita. We really were matching Western standards. I have to say that we've not been able to sustain these outcomes. It's not as terrific as what it was in 2013, but we're round about there. We still have very good results that are comparable to your STS database and EACTS database, and we really have some very good results. Lately, it's a tribute to our surgeons, to the whole program, of course, but it's a very difficult benchmark to sustain, and it's always challenging us. And I have to say that at this point of time, it's not as good as 0% for arterial switch and total veins, but we're close to that. And it's been fantastic the way we were able to actually improve outcomes with the help of simple quality improvement initiatives. But the challenge is of sustainability. we know that this is not sustainable unless we keep working on our QI initiatives, and unless we keep shoring up our resources, unless we keep retaining our nurses. And also the challenges of scalability. What we do here in AIIMS may not be scalable on a large scale, because we are also very resource constrained. Boban knows it from first-hand experience. So these are the opportunities for all of you and who are there in the United States. And I think the first very obvious is to facilitate funding, and not necessarily through personal donations, but through finding ways to support foundations like Genesis, who have this phenomenal commitment really to the cause. And then, of course, to strengthen programs and institutions. Boban's involvement with us, and of course, it's been quite fantastic. And I think there is these opportunities, and it's of course careful nurturing of partnerships with institutions and building durable systems. There are camps and outreach initiatives that we do that I think are good opportunities to get started, really, but these are not, again, sustainable. It's actually very tempting. It's just to give you a flavor of the region, but then what you have to do is within the programs. Screening at birth is talked about, but we're not ready yet for nationwide screening. Academic exchange is something that we can implement right away, and we'll be very excited to do that. This is a wonderful forum to do it. And then the strategies really is to build partnerships with institutions. I think that's something that we have to, that you can do. And particularly areas that need attention are intensive care that really is needs to be improved everywhere, including in our own institution. Surgical expertise in some places. Newborn transport is a huge issue, and I think we're presenting a paper on what poor transport does to patients in our part of the world. And of course, the Annals of Pediatric Cardiology is a journal that's come out of India, and already have found a lot of participation from the American community of Indian doctors, and that's been fantastic. And then, of course, helping with individual patients, something that you will, that's very, very instantly satisfying. Catheter hardware, Boban has been very generous in bringing in and giving us catheter hardware. It's helped so many patients, particularly the stents that he's brought, because we don't have stents available in India easily, and that's been fantastic. So what can you learn from us when you have the opportunity to work with us is the fact that we deliver care with very limited resources, and very different from the United States situation. For example, in cardiac catheterizations, we do not have biplanes mostly. We do single plane caths, and we kind of do it differently. We really get all the information from echo and then try to minimize procedure time. We often share our facility with adult cardiology. We reuse our hardware, very careful about hardware. We think about what we use. We try to improvise and use inexpensive devices, and then we share personnel, and we don't do anesthesia very often. So these are things that Boban has seen again firsthand, and this is an experience that I think will be of value, because if you do catheterization under these challenging circumstances, I think you become better overall. And then, of course, doing research with us, there are tremendous opportunities. So with this, I have to say goodbye. I really thank you for your attention. I thank Boban for this opportunity. I thank Prema for all what you have done to us for our patients with your very generous contributions. Thank you all.
Thank you, Dr. KK. That was a very informative presentation. So my question to you is, will you be able to stick around until Mrs. Prema's presentation, so we can have people ask questions to both of you? Is that something that you can do?
Yeah, I think so. I think it's still early hours, so it's 5 a.m. So I think it's still okay.
So I have.
I'm sorry.
Go ahead. I'm sorry.
I think I've seemed to have taken a fair bit of time. I'm really sorry about that.
That's fine. Thank you for this excellent presentation. And we have more people coming into the room as well as joining, so it's great. Thank you for everybody who's joining. And next, I want to introduce Mrs. Prema Sagar. And we have been emailing all the communications to you, so I think you know her very well. But Mrs. Sagar and her husband, Mr. Jay Sagar, are founder trustees of the Genesis Foundation, which is the philanthropic organization that we are trying to introduce to our community in the US. It was started as a PR firm in 1992, and then they have collaborated with a US company, and she is the vice chair for the Asia Pacific region. She's here actually for part of that business too. She's also the founder president of Public Relations Consultants Association of India and founding member of the Public Affairs Forum of India. She was named by the PR Week among the 50 most influential people in the PR in the Asia Power List 2014, and by the Impact magazine as among the 50 most influential women in India in the field of media, marketing, and advertising. She was the first Asian to receive the honor of being inducted to the ICCA Hall of Fame. That was in 2005. And more relevant to us is she's on the advisory council for the Doctors Without Borders India. And above all, she's a great philanthropist who has turned a personal tragedy into a major force for good. And I have had the good fortune to get associated with her, program and the foundation in the last month, and have had the opportunity to have a couple of conversations. I've had the opportunity to see her passion for this firsthand. So I think as a community here, we are very fortunate to be associated with her and the foundation. And without further ado, I would welcome Mrs. Sagar to talk about Genesis Foundation and how we can collaborate.
Good evening, good evening, and good morning to people on the who are in India and over here. I want to introduce to you Sharanita Keswani, who actually oversees the children. We have Srivatsan in India, who looks after the children with heart issues, and Sharanita focusing a lot on cancer. And there is one more person who looks after thalassemia. Can you hear me? Yeah. Where did this go?
We can hear you online, Prema. Thank you.
Okay, thanks.
So you can use the mouse, that'd be easier. What happens is
okay,
so
that's how
you
it
can
is.
just do
Okay, all right. Okay, so just as a start to tell you about why did Genesis Foundations get started? Many years ago, I think it's about now 32 years ago, we lost a child in Delhi, and unfortunately, we were just told after 48 hours that there was a heart problem. We didn't know, how does the doctor know it was a heart problem or any problem, but the child was gone. Having no answers to any of those questions, we went to Mother Teresa's home and we started working a lot with the children over there. Two of the children that we worked with, they are in America. They came here because there were no available, no doctors who could work with them. There were different kinds of issues, and there are stories about these two children. They've been adopted and they are living here, and one of them is actually married and to a very wonderful American man. And they were uneducated children who grew up, and they are so happy with their own children. They have two boys. Um, the other one, of course, is adopted, not married because of his physical situation. He didn't have that. Now, going to Mother Teresa's home with cribs and cribs and cribs, and they're there today as well. When a child died, we never knew why. And I also don't know why there are so many children uh, who have this heart issue. I will sit with Dr. Kumar when I'm back because of all the information that he has as to why are there so many in the world, in India. Is it only with poorer people? Is it got to do anything to do with uh, the kind of nutrition they get? Is it genetic? What is it? We still don't have, we talk a lot about it and we don't get the answers because we really don't um, understand why it happened. So the Give Life a Chance was really to get people around us for many years to support children. Let's be honest, money has only come now to us in India. I know that as a military background, well, sometimes my mother would put 100 grams of butter on the table, and it had to be that was it for the week. Now we have too much, and yet we cannot give, and we can't do that. This is not going. Okay. So I hope everybody can see this presentation. Okay, so we have on with us is about mission. The mission that we wanted to do was really to provide financial support. By now we have so many doctors and we have so many places. It's never enough, but at least we have financial support. The vision that we have is really about the child, absolutely about must not die. There are times when we get a call, whether Sharanita or whether Srivatsan, they get a call and say that the doctor called from AIMS and said, we need to have this child's operation now. And the paperwork was not done, and that we just said on a phone, please go ahead. So that is exactly what we want, is the relationships with doctors, hospitals, and ourselves and givers. Our commitment is very clear that the trustees will support all administrative, the cost of administration is so clear that anybody who's giving them, whether it's 100 rupees or 1,000 rupees or a few lakhs of rupees, it is whatever is donated will go towards the child. Because we know from many foundations, 30%, 20%, 10% is administrative. It's not fair because I wouldn't give that money to anybody if that money was only 70 rupees going to the child and not 100. So to go forward, that's my husband. He's a lawyer basically and has been very supportive. And he also, Sharanita took him to the Tata Memorial Hospital in Bombay. And this picture is actually about where he felt really awful when he saw the children, but he found them getting better and smiling, and you'll see some of those videos that are there. That, of course. We have an advisory board for quite some time, people who support us in many ways. And they are from India, they are from Switzerland, they are from London, Canada, Singapore. All this is really about how we can expand our footprint, and what today we are here for. We can never ever think about that we reached this situation where we have already 1,000 children, and we hope that we do 1,000 in this year. I know my husband says, can you just be um, just think that do you can do 500 and not 1,000. But I think the way in which we have been uh, uh, you have invited us here, and everybody else on the line have sat up, whether you are sitting at home here or you're in India. It has been such a big support to us, and I can't tell you, it is difficult for me to speak today because I feel that um, this putting this time and putting this heart to this heart of children is something which is very difficult for me to understand, that how we got to Dr. Kumar and how did we come here and meet all of you. Much of the analysis has been done by Dr. Kumar, and we know that there are very, very sad moments. Last night I put up this presentation because I saw this thing about the India ranking in 143 among 188 nations in health study. And when you go through all of this, you realize it's only getting worse. So how are we going to catch up with this? It's unbelievable. And can you imagine, if you look at the numbers there, that behind countries like Sri Lanka 79, China 92, ever war-torn Syria 117, and Iraq 128? And where is India? Ranks health indicators, ranks India 6 at places ahead of Pakistan. And actually, we are told that these numbers are even not yet quite right. You want to add anything to this? No. Okay. So just want to show you this video, which gives you a sense of the real thing of what we do. Don't mind the 750, it's the old one.
There is no reason why any child in this world should lose his or her life because of a lack of sufficient funds.
Came to us, she was extremely blue. She had difficulty in walking. She couldn't even stand. So Ume has a condition called tetralogy of Fallot. In tetralogy of Fallot, you have a big hole in the heart and narrowing of the main artery to the lungs. So because of this narrowing to the lungs, the whole of the blood goes to lungs for cleaning up. While in Ume, there was only trickle of blood which was going to lungs for cleaning up. So she underwent a surgery called TOF correction. That means you close that hole in the heart and you open the main artery to the heart. So now her heart is almost the heart of each one of us.
सभी ने हम लोग मदद किए और यहाँ पर कोई फर्क नहीं है, यहाँ पे जरा भी एकदम मतलब कि सब लोग हाथ हैंड में सभी वर्कर ने भी, और यहाँ के डॉक्टर भी बहुत अच्छे, हॉस्पिटल में बहुत हेल्प की हम लोगों की, कोई कमी नहीं छोड़ा। अब अच्छा लगा। फाउंडेशन जो है हमारे लिए बहुत जिंदगी की तरह है, जिंदगी भर इसके शुक्रगुजार हम लोग रहेंगे। और मैं यही चाहूंगी कि जिस तरह से मेरी परेशानी दूर हुई है और भी बच्चों की परेशानी इसी तरह दूर हो, क्योंकि जितनी जल्दी यहाँ पे काम हुआ कहीं नहीं होगा। I think what Genesis Foundation is doing is trying to build a bridge between the people who have with those who don't have enough.
Um, the humanity that I've gotten to witness courtesy the Genesis Foundation today is rare. You know, oftentimes in life, especially in urban life, where many of us are caught up in the rut of living, earning a livelihood, making ends meet, playing the different roles that we're playing, um, we forget that there are many young, invisible children that need our help. And what Genesis is doing here is giving many families the opportunity to find cures for critical illnesses for their children. Not only are they funding these very, very difficult surgeries, but they also handhold. They take the family through the entire process. And I'm very, very, very proud to be associated, to be the doctor, and to help Genesis make a difference in the lives of children like Ume, who I met today, and see a smile on their parents' faces and give them a chance to live.
So this child's father abandoned them, and they didn't have the money, and they decided that the mother decided that she would continue to come to Delhi and to get the treatment. And it is really sad where you find right now in Max Hospital, there is a child from Iraq who was going through 6 month old, went through the surgery, and when they came out of the surgery, the parents had left for Iraq. And what we realized this morning, there was a message that they had come back because they believed that the child was now treated well and will be pretty okay. So the areas that we work on is what Sharonita does on hope, everything to do with children. And care is all about the hospitals, the doctors, all the support that we get. And then on the giving, of course, we'll speak a little more about that. The areas that we work on is events. We do a lot of events with music. And I think what we believe is that we put a smile on the face of the life of children and their parents. We don't want people walking around, feeling very sorry for them, because it is better to celebrate that they are alive. And the CSR programs in India, um, I'm sorry to say that in CSR programs in India, as I was saying earlier, was that people are only giving money towards education. That's the easiest, best way for just you've got to do it. There's a 2% of a particular amount of profit. Yeah. And so that is wherever we go speaking to companies, we have not received monies because they say we believe in putting the money into education. People who are from there, Kriti and others in Delhi, they do go and harangue companies that you have to think about healthcare as well. So we are hopeful. We have one company that has given us some pretty good money, but beyond that, we haven't achieved it. We also putting a lot of information on Learn because we are putting up information on our website so that people know what we are doing. What does it mean to be having a problem with thalassemia? Many people in India don't understand what thalassemia is. And so heart and what are the kinds of surgeries, etc. We will send you some of these things. I know I don't want to spend too much time on the details of it, but that's what we've done is created this infographic presentation so that you can read about all of the areas of hope and care and give and the impact of what we do and what are the awards that we get. Awards are good, but I think more important is that people should understand what we're doing by putting their wards entries. So, anything you want to add to this, Sharmita? No? On the hope front, 102% increase in the number of children supported under hope in 15 to 16. As I said, I hope we can do 200% or 400%. I think we will just keep going. The number of children that are being treated in on the areas of cardiac disorder, cancer, and thalassemia, I want to tell you that earlier we had 5 areas, now we are 3, and as I see that it is about 70% on heart, and the balance is cancer, and a little bit is with thalassemia. These are the process that Sharanita has, this process with when we start, when we get children, and how we work with through the process.
Would you like to go through that a little bit about how the children?
Yeah, please.
Just briefly. Basically, the bulk of the children come to us because they land up at all the hospitals. We're very particular under our care program to select the hospitals that we work with. So we will work only with the very best because naturally we want to see that the child gets the right kind of care. And this is a super specialty area when we talk about pediatric cardiology. And as we know that there are lots of hospitals, even in India, which do cardiology, but not so many. You saw from Dr. Krishna Kumar's presentation, they're like something like 40 to 50 that do pediatric cardiology. So we are very particular to see that they have a dedicated pediatric cardiology department. So what happens is that in India, there will be people from villages from all over who will perhaps go to a district hospital first and gets picked up from an echocardiogram, and then they discover that it might be a cardiac issue, and then the doctor there refers them to the metro city. So they come with literally with babies in their arms. It's very tragic to see, and they land up at these in the big metro city, and they land up at these big hospitals, which is so intimidating for them. And the other part of the work that we do is that one is a very close relationship with the doctor, so that we are able to ask direct questions about the child. We need to know the everything about the child we are supporting. And the other thing is that we have very close relationships with many of the large hospitals have social workers. They have a social worker department. And if they have a spirit of philanthropy, these hospitals do collect donations from donors. And so we do work very closely with them to see that the funds do go to the children. And they do the first level of screening in tandem with us. So most of the kids are coming in this manner. Sometimes we have relationships with the district hospitals, and we are then able to directly have contact with the doctors in the district hospitals at the state level, and they send us the kids. We take them to the metro city hospitals, to the doctors that we know. And we're very sure, in the case, we don't decide, obviously, we don't pass any judgment on the medical treatment. That is entirely up to the doctor. But it is the close relationship that makes us feel confident that the child will get the right care. Of course, we have screening and due diligence, where we make sure we support families with a monthly family income of less than 10,000 Indian rupees or US dollars, 150 USD per month, and under 18 years of age. So we have basics criteria of that nature. And of course, then the doctor has to decide what is the prognosis. And we try as far as possible to have a face-to-face meeting with the patient and the family. In places where we don't have our own office, we have volunteers in big centers, like now in Kerala, because we've seen that that's a state which there's a lot of philanthropy being done there, and a lot of charitable work that is being done there. We had one in Bangalore. We have a very active person in Bombay. And of course, we are in Delhi. So face-to-face meeting is very important. And every bit of the money that we collect goes directly to the hospital. So we, on behalf of the patient and the family, do negotiate with the hospitals to get the best possible rate for the family. And they get, if it's very expensive, they'll get part of the payment from us, the rest they'll get from other donors. And of course, on completion of the treatment, we insist that we get a discharge summary to know that it's all over, and a receipt from the hospital that the payment has been made. Now, this is very important when we have large donors who want to understand where the money is going. And of course, we have from the very beginning never paid the a patient's family directly. What happened to this? Yeah. So this is basically numbers of our numbers, that 77% of the kids that we support are suffering from congenital heart disorder. And we mentioned this already, that our increase in the area of cardiology has been mammoth, 161% increase over 2014-15. And last so many years, we've been growing at the rate of 42%. And of course, cardiology, I was talking to some of them, the success rate in cardiology is very high, given the kind of technology we see in this area. You could close that, no?
फिर मेच्योर हुई थी, 7 मंथ में हुई थी। इसको जो है दिक्कत होने लगी, अजीब सी लगती थी अपने आप को, इसको अटैच जैसा पड़ता था, पता नहीं क्या होता था, अंदर अंदर एकदम से अकड़ जाती थी। वहाँ के डॉक्टरों ने बताया कि इसके दिल में छेद है और इसको बहुत दिक्कत है, आप लोग इसको दिल्ली लेके जाइए। मेरी इनकम अभी उतनी नहीं है जिससे कि हम अपनी पेरों की इलाज करा पाए। इन्होंने जो है हमें हमारी काफी मदद की, बल्कि काफी क्या पूरा का पूरा उन लोगों ने ही खर्चा उठाया पहले भी ऑपरेशन का। पहला ऑपरेशन तो इसका ठीक ठाक हो गया, उसके बाद में ये ठीक हो गई। फिर डॉक्टर ने कहा कि एक ऑपरेशन अभी और कराना पड़ेगा इसका, क्योंकि अभी इसके दिल में जो होल है वो अभी हम नहीं बंद करे, क्योंकि बहुत वीक है ये। 1 महीने पहले हम लोग आए थे इसको दिखाने से, डॉक्टर ने कहा कि इसका ऑपरेशन अब कर सकते हैं, ये इसके लिए तैयार है। दूसरी बार भी आप लोगों ने हेल्प की, इसकी वजह से आज मेरी क्यों बिल्कुल ठीक है, मेरे पास है, हमें हिम्मत भी आपकी लोगों ने दी है।
So the hospitals and associations, it's interesting to see that the number of private hospitals, and when you look at Delhi, we have just AIIMS. And when you go to AIIMS, there are sometimes 2, 3, 4 children on one bed. And then there's a long list of when you can be. And the nicest thing is that what they do in AIIMS is they say that this child can wait for 4 months. We have to do more emergency surgeries. And of course, Gangaram Hospital and Dr. Shroff charity for the retinoblastoma.
These are actually for cancer.
Yeah, for cancer. And Mumbai, these are the ones that we've been working with, and recently also with the Tata Memorial Hospital, Sion Hospital, Kokila, the Dhirubhai Ambani Hospital, and Jupiter.
Actually, these private ones are all the new corporate hospitals that have come out, mainly, which have the super specialty tertiary care hospitals. You must have been hearing a lot about these.
But most of the children are being treated in Chennai and Cochin. So it is
sorry, I was wanting to. Should I minimize it?
Let me show you. Okay, so cancel. If you click here, that should be good.
Yeah,
this one, right?
Yeah. You were saying?
Yeah, I mean that a lot of these private ones are the corporate hospitals, and of course in Kochi, our big star is the Amrita hospital. That has been a lot of cases, especially the neonatals. A lot of them are being done there, the cardiac surgeries.
Kolkata is a
I know it's
newest.
barren. Yeah, but that's for cancer. The Tata Medical. Did you have any question? Yeah.
How does it work with the private versus the government? Is that where you negotiate a lot?
We need to negotiate with the private, but as you can see, there are a lot of government hospitals which are doing primary and secondary healthcare. Not all the government hospitals have the kind of specialized care that we require, and in all the areas. So while it might seem that it is logical to go to the government hospitals, but they often don't have the facilities. And also, what happens with the All India Institute, which is in Delhi, the Premier Research Institute, the waiting period is so long. So these families, we often ask this question, but why so many private hospitals? But they cannot get a bed in the government hospitals very often, so they have to go to a private hospital. And really, it's most importantly, it's the facilities that we are looking at. That who has the facilities that we require, because these are all super specialized areas that we're dealing in.
The social workers, they contact you?
Yes, and the doctors. We know the doctors very well, so they just pick up the phone and call us. They have us on email, on phones, on texting, and then the paperwork starts. They've all got all our forms and our documents with them.
Yeah,
They're very
somebody-
familiar with it.
In some patients, at least, the prognosis is going to be bad. So how will you like the life expectancy is going to be 30 years, and they need continued care. It's not one time. Maybe pediatric cardiology, you do proton surgery, whatever. Some cyanotic heart disease needs continued care.
Yeah, but for cancer, that's the problem.
Yeah, cancer is very much the problem.
Can you
But
repeat the question,
Yeah.
because the audience cannot hear, and then I think we can keep the questions towards the end, otherwise.
Okay.
But keep going. Just answer.
basically, the point you made was that what do you do when the prognosis is not very good and the patient would require care even in a prolonged period of care, right? Is that what you asked? Well, I think it's no one straight answer. We look at each case on a case to case basis, and there will be some cases where we are not confident and we do say no. But most often, what we try to do is we say that if the medical community is wanting to take that chance for that child, and the parent is wanting to take that chance, the most important thing is the family is wanting to go ahead with it, then we do our bit of contributing. We may not be able to afford to pay for the whole thing, but we make a substantial contribution because we want to save the life of the child. And sometimes they'll say 60% chance, we take that chance. And because we also know that for children, if you catch it in time, that the chance can be pretty good. So we do try to take that chance. But there are some cases where we are not confident and we don't have that kind of the funds available to us, and we have other children. It is a difficult situation. We don't have infinite funds, so there are times when we do have to take a tough decision and say we will give it to child A vis-a-vis child B. It does happen.
But that's really, once in 100 that we say that we are going to, because we do believe that there's always a chance to live. And with heart, I don't think we have any much issues, but in cancer, we do have a lot, and we have lot of number of kids. But we say that suppose that child was mine, and suppose that you want to go through the treatment, and it doesn't work. It doesn't matter. So most of the time, that's it. It's only very, very rare, actually, when we do not go ahead with it. It's a very difficult decision. It's very difficult to say it's really at that time. So we have a medical board. There's a new website coming up in another 2 weeks. And we felt that it's so important for us to have people that we can speak to, whether they are in whichever hospital. But if there is a child in another hospital, and we do need to know what they think and what's their decision with how we should go forward. So thankfully to Dr. Krishna Kumar, who accepted to be on our medical board, and Dr. Dagar from the Max Hospital, where we do a lot of work with them on heart and on cancer. And again, there are 2 doctors, and Amrita Mahajan does cancer and thalassemia. So these are the 5 doctors that we have on the board. And the ones for thalassemia purely, they are very well known. All of these are very well known. And I know that doctors do not wish to be on any of these, and they have a lot to do, and also don't want to spend time on meetings. We are not doing that. What we are doing is consulting with them when we are in a spot about what we should do it. Sometimes you need some second person who's going to tell us which way to go. So some of the doctors on the pediatric cardiology we've been working with, again, they have been extremely supportive to us. And sometimes you feel you're really blessed because whether it is a child coming from our side or the child from the hospital, it works automatically. There are no issues that we've ever faced with the doctors, whether it's morning or night or whatever. This is a beautiful video for you.
The average heart operation was almost equivalent to the average annual income. And when financial reserves are low, that's a big burden. Our innovations have been to reduce costs. So we have innovated consistently to be able to deliver the same quality at a reduced cost. We have pioneered here is in being able to diagnose heart disease before the baby is born. My name is Krishna Kumar, and I'm a pediatric cardiologist, and I head the department of pediatric cardiology here at Amrita Institute of Medical Sciences. This program is in some ways one of the pioneers in setting up a pediatric heart program to take care of children with heart disease. When I was doing my DM, during that period itself, I realized that there is a need for specialized care for children with heart disease. And there was no such system really in place in India. And I felt that I can serve the needs of my country far more if I were to come back and establish a program. What was very, very obvious when you take care of children is that these are patients with specialized needs. And they need specialized training. And unless you get that training, you can't do justice to this population.
ശരിക്കും പറഞ്ഞു കഴിഞ്ഞാൽ ആ സമയത്ത് സഹായിച്ചത് ജനസിസ് ഫൗണ്ടേഷൻ ആണ്. അവരുടെ സഹായം ഉണ്ടായിരുന്നില്ലെങ്കിൽ തീർച്ചയായിട്ടും കുട്ടി ഈ സമയത്ത് ഞങ്ങൾക്ക് ഉണ്ടാവില്ലായിരുന്നു കൂടെ. അതുകൊണ്ട് തന്നെ എന്താ പറയണേന്ന് അറിയില്ല. നന്ദിയുണ്ട്.
If you look at the mid-90s to now, there has been a considerable growth in the specialty. From a handful of institutions that could take care of children, now we have at least 30 or 40 institutions that have the capability of taking care of children. However, if you look at the magnitude of the problem, there's a lot to be done. So we have a long way in terms of making sure that the average child who's born with heart disease has access to good quality care. Challenges are numerous and at every level. Firstly, the child needs to be lucky to be diagnosed in time. And for the institutions that are able to provide pediatric heart care, it is expensive. Why is it expensive? Because it needs a lot of intensive care. As a result, the costs of an average heart surgery is well beyond the reach of the average family. Not really in the realm of corporate medicine or profit-oriented medicine. This is much more humanitarian. When it comes to a child with heart disease, the whole sentiments are different. So everybody is making an effort. Investing in a child with a relatively straightforward heart defect that can be corrected may actually be a one-time investment that will change the life of the child.
മോശമായിരുന്നു ഞങ്ങള് കൃഷ്ണ സാറ് പറഞ്ഞ ജനസിസ് ഫൗണ്ടേഷനെ കുറിച്ച് പറഞ്ഞത് വളരെ ഭയങ്കര സഹായമായി പെട്ടെന്ന് ഞങ്ങൾക്ക് അത് കേട്ടപ്പോൾ ഇപ്പോൾ ബെറ്റർ ആയി കുഴപ്പമൊന്നുമില്ല.
Professionals has become advocates for our patients. and interact on at a greater level with the society. If we can try and speak on behalf of our patients at whatever forums and opportunities that we come across, to actually make people aware that this is something that can be fixed. Probably one of the most noble ways by which you can demonstrate social responsibility. Once you can ensure that the money is spent meaningfully, that the whole process is very credible. So if you invest, for example, in a child who is saved, and then you get a feedback on the child's first birthday, the impact is massive. What we need is a robust system, and that can be created through dedicated NGOs that can facilitate the whole process. Over the last 1 year, we have actually done over 50 children. But it's not the numbers alone, it's also the challenges. So we've had several incredible challenges that we've overcome with the help of intervention from Genesis Foundation. It's very difficult to actually handle the double burden of having a child with a problem together with trying to find the financial resources to overcome that problem. And that's where Genesis was making a huge difference. So we've had several instances where a baby was born with heart disease and needed surgery within the next 2 hours. If you tell that to a family that you need surgery, a baby needs surgery, but you need to be able to raise this kind of money within the next 2 hours, it's just not possible. But Genesis was able to actually help us in those situations, those specific, really difficult situations where it's a matter of life and death. Within half an hour, they have to come and give us a response. They would give us a commitment. So the real distinction between the Genesis Foundation and many other fund providers is that they're willing to take on the difficult cases. They're willing to take on the newborns. They're willing to take on the risky situations where there is a little more uncertainty about the outcome. And that to me is very significant. Because if you try and say that you're going to save every single child in this country, that's unrealistic. But if you can show the way it can be done for others to follow, then you've done something for the future. You've made a difference. The important thing is not just the number of children that are saved, it's the example that you set.
Dr. Kumar, that's for you. This video, it says everything for us. And if you last budget last year, the Prime Minister said he was going to put 2,500 crores in healthcare, and 2 months later he took it back. So we saw one of the father who sold his little kutia in the village, and his daughter was brought for surgery. He had nothing left where to stay. And that for the daughter. And you look at people in the villages, they don't differentiate. The richer ones differentiate about where the money should go. And that's some of these experiences, there's so many of these. It's very difficult when you have a prime minister who is not interested. And our problem is going to be, how are we going to go to his office? And I'll talk to you about that in a minute. These are doctor testimonials. I don't think you need to go through it, but it's all good, of course, because running and we are like a family with them. They know us, we know each other, and it has worked exceedingly well. That's very important. Your reputation is so important. And so we have to be extremely careful about how we work with doctors and hospitals, and how sometimes we are negotiating with them on the monies, etc., and all of that. But it has always come to a situation where we have never said no. On the giving part, I'll go through that just quickly because I know it's late. When we are looking at cost of treatments and you look at them in dollars, these dollars are something that saves the lives of the children. And when we are looking at let's look at the cardiac disorder area, anywhere between 2,300 and 3,000, going right up to 7,700 per child. And most of it is, I think, in the area of 3,000. It really does work very well. However, what we are looking at our CSR programs, we talk about cancer concern, we talk about winning hearts, and we talk about thalassemia support. There are the kind of numbers that we've put. We'll be sending you this presentation. You can see more. I know you must be tired by now. And we're doing a lot with all these events. Please do come for them in India. It's great fun. We have CEOs who sing when we raise funds from them. And then we do Goa Rhythm and Blues Festival in November. And then we do it in Kasauli, which is in the Himalayas. And this what has sustained us hugely. What we are doing in India, we want to do very much about Power of One. We'll talk about that just in a minute, and I'll go through this because of the time. The donor testimonials, great supporters that we have. They're CEOs, lots of them. A lot of people who support us during events, fundraising. Let me see which this one is. Many years ago, me and my husband lost a child. I think we'll go through the next one. Is it okay with you? What we wanted to do was to find a place where we could get over it and help children who were... Yeah, I've said this, so can I move on? So we went to Mother Teresa's. Okay, so this is the $1 a day for GF kids. And this is something that I was speaking to a doctor who is in Arizona. She's moved from India back to US. And I was talking to her this morning, and she said, if you're looking at $1 a day, I mean, even a coffee is not that much. And so she was talking about it's a great idea to go forward, and people will become much more giving in time to come. So we'll come with a plan on how we can move forward on not just the big numbers, but also collect on a daily basis from many people the kind of work that we can support. This one, again, I'm not going to go through the details. It's more about what we've done, and you can go through it. Boban was on the call with me, and we are talking about what's the dream. This is the dream, is that people, the doctors from US and the doctors from India, we go to the Prime Minister's office, and Sharanita.
I'm sorry.
The Prime Minister's office, and not the Prime Minister. The Prime Minister's office, that children are dying and nothing much is being done, and how he can support us. I don't think that we've done these kind of hairy, scary things, but I think it works when we decide that we want to do something, we do it. So we want definitely to go there and say that you support the children through us, through the foundation. If he was to give them the funds, we are happy to give them reports on a daily basis. But where is the money going to come from? If they're not creating doctors, hospitals, we are not have nutrition for them. Some of them die because of lack of nutrition. How is it that we are going to make children as children who will be treated well? They can go to school and become young men and women. Now, in this medical camps, that's another thing that we want to do. In the areas of doing these camps, the machine, you are not allowed in India to take it anywhere outside the hospital. So we have to do a campaign against the fact that why can't we do these camps so that we have a knowing of how many of the children that we are doing this scanning, and that they will then finally know whether the child has what issue do they have and can we help them. There is no scanning happening anywhere in India. Then the way of life is a building a culture of giving. We've been doing a lot of this culture using communications, and it has helped. It has helped about people giving more this year than last year. And that's why Eyes of a Donor. I'm not going to take you through that. I just want to say you've been here for a long time. Thank you so much. Nobody would do this at this time of the day, full day of work. Thank you for your time and your heart. We need that. Any questions that you want to take?
We are giving questions
All right.
online. Santosh,
Okay.
bring up questions now.
Yeah. You got our
Thank
email.
you.
Thank you for coming, guys. Thank you very much.
Appreciate it. Thank you.
I'll actually take a couple of your cards.
And you have brochures, right?
I have some brochures. Prema, did you?
Okay, there it is.
Hey, thank you guys for sticking around. We will wind this up in a couple of minutes. We have some questions that are posted online. We will answer that. We'll have the Genesis team answer that, and then we will wind up here in a couple of minutes. But again, thanks for sticking by. Also, in the meantime, I want to thank the Genesis team, Mrs. Prema and Dr. KK for presenting to us. And thanks everybody for coming online. I think it's just a start at this point. We'll have to have more discussions in the group, in the community here, as to how we are going to proceed. But let me get Santosh over here so we can pull up the questions and answer for you.
So I think some of the questions are already answered here.
Santosh, just read the question so I can answer that.
Okay. So where should I start? Compliments. So this is the question from Chandra's in Houston. He is a EP physician there. Considering the constraints, do you often find yourself having to make a call on where to focus your resources, specifically what forms of heart diseases get the resources? He's referring to those who could have potential biventricular repair versus single ventricles. What he's saying is complex versus not so complex. If so, how often and how do you prepare yourselves for such a decision?
So, Dr. Krishna, can you ask him to come online and see, and then Prema can answer?
Yeah. Actually, can you hear me?
Yes.
We do not do single ventricles through charity as a rule, because we just have so many correctable two ventricles, and we don't believe that's the best way of using charitable resources. So we do not actually approach them at that situation. And we do have 6 single ventricle kids coming in, and but at the same time we have a large number of biventricle kids who need help. So we don't actually, we have to triage, and it seems unfair to the single ventricle kids, but at this point I don't think that's the best use of our resources. So yes, we don't do it.
Okay. Anything to add, Ms. Sagar?
Basically, as we do is that we have the decisions that the doctors tell us, and that's why now we have the medical board if we want a second view. Yeah.
The next question is from Pankaj. Does Genesis has a system to follow up on these kids, like whoever gets operated? Boban can.
In most of the cases, we do. The child comes back for
Exactly,
treatment
after the surgery.
and then they keep coming for till the
Uh-huh.
doctor says, okay, now you're fine, you don't have to come. Often when they go back to the village, finally what happens is that when they get cheaper, sort of mobile phone,
Uh-huh.
I think they keep changing their cards.
Oh yeah.
So
yeah.
that becomes a big problem. But the ones that we have their numbers and they continue with them,
Uh-huh.
then we lose them. And if the issue comes up, then they're very smart. They connect with us again.
Okay.
Yeah.
Okay. So it's up to the
We
parent.
are,
Mhm.
yeah, no, but we are making efforts in Amrita to collect data. So we have actually, Boban has seen that system. What we're doing is we, as far as possible, track all our patients. It's a little better in Kerala. Everybody comes back for follow-up. We have 90% follow-up.
Very good.
So it's possible if the patients are motivated, and we try to motivate them when they come for their first evaluation.
Okay.
Ritu has asked a question.
Yes. So the next question is from Ritu Sachdeva from Emory. It is impressive to see the work being done by Genesis, but clearly more needs to be done given the burden of CHD in India, which is congenital heart disease. Has Genesis worked with a community of doctors in countries outside US for fundraising? Can they give any ideas for a sustainable model of funding cardiac surgeries in India that we can adopt?
Yeah, of course that Dr. Krishna Kumar has introduced us over here, so it's given us a very big opportunity. But what I would really like Ritu to help us to help us how we should go forward. That will be very helpful for us.
Then
Devyani?
Devyani, so she's asking about medical board, the composition,
Yes.
process.
Devyani Chaudhary from Harrisburg. She has two questions. One is, are you collecting outcome and long-term data, which KK has answered. And then her other question is medical board composition and process. How the doctors are chosen.
Yeah, so basically the experience that we've had with various doctors over last so many years, and we felt that those who were honestly to say is that they were the best ones, the ones who actually always helped us and at any time of day or night. So the experience has been exceedingly good for us and helpful for us to make decisions.
Any other questions? Anybody who is on phone, do they have questions?
So I think we are going to wind up here unless you have any more questions. But this is a continuing conversations. I don't think this is this is just the very beginning. We are just scratching the surface. So I want to thank a couple of people quickly, and especially Dr. KK and Prema and Sharanita, the Genesis team, and also Santosh for making all the arrangements and making it actually work. And also for all those who have attended on a Friday evening. I guess it's my mistake to put it on a Friday evening, but next time I'll make a note of that. But having said that, we will keep this conversation going, and we are going to come up with plans to rapidly raise funds through a crowdsourcing model. Like, we are going to target, say, 500 new contributors in the next 6 months, which are small contributions, $25, $50, $100, which is going to make a big difference. We also need to, as a group of cardiologists, we will continue our conversations as how we can formalize a group and continue our contributions in other ways in terms of research, collaborations with institutions, physicians in India, CAMS, any other way that this is going to be a collective process with input from everybody. So with that, I thank you. And I think Prema has one more announcement to make. So let me give it to her and then we will wind up. Thanks, everybody.
Just take this. First of all, thank you to everyone. It's from my heart. On next week, we're going to send out a mail which will have everything on the documentation that we can share with everyone. Also, from where we will be able to connect in terms of how the money can move forward, and we are looking at very different models, and those models are open to you to decide which way you want to do it, where we get the biggest buck, or what do you say, for the bang for the buck. Yeah, so that should work. We will continue trying to see that we don't lose even 2% when it comes to the India side. That is the challenge. But if we now create Genesis Foundation in US, and if that helps, we will do it.
And one other quick program note, I also failed to mention this. I want to thank Devyani Chowdhury, who is online now. We have been working to arrange this meeting. Also Ritu Sachdeva, we have been working to get this meeting arranged. He's also online. Couple of people who couldn't attend but have been working with us. One is Shelby Kuti. He's in Omaha. He's been working with us to make this happen. And also Dr. Balaji, he also couldn't attend, but this is an ongoing conversation. We have recorded this. We will send it and other documents, and we will stay in touch.
Thank
All
you
right.
so much.
Have a good night. Thank you, everybody.